So thank you very much. The time starts now for 12 minutes. So endocarditis is a complex topic, and you can really dissociate endocarditis guidelines from the previous background. What we know endocarditis, it is one disease which no cardiologist wants to treat in the practice. We want to read about it, but really one don't want to treat, and this has been the pattern there for nearly 150 years since the people really understood what endocarditis. The reason is that it's a disease with a very high mortality and morbidity, no doubt about it, and more important to highlight is that 50% of the patients will require surgery. The population is getting older, more incidence of staph, and we have more prosthetic walls and catheter devices and implanted devices, making the issue more really complicated. So the European people, they came out with the guidelines in 2015, and then after nearly 8 long years, they came with the really updated guidelines. Today, in the next 10 minutes, we're going to discuss what is new in the guidelines as compared to 2015 guidelines. This is a big document. It's a 98-page document. It has got 34 new recommendations. And there is more clarity on certain aspects about regarding the diagnostic patterns which we use in our clinical practice, regarding outpatient parenteral antibiotic therapy. That means you can discharge the patient and they can continue the treatment on the regular injection with the general practitioners. And there are certain specific scenarios which have been discussed. So we'll go through one of them. The things which have been changed or not changed is that the clinical criteria and the microbiological criteria for the endocarditis remain the same from 2015 to 2023 because they are based on the modified Deuce criteria. But what is changed is the imaging pattern. So the imaging pattern is now the European Society believes that the echocardiography, cardiac CT, FDG, PET scans, and the WC labeled scans are nearly similar as a class 1 recommendation. So the imaging, whatever the method used for imaging, if you find the clinical criteria for endocarditis, it makes the patient a strong candidate as a major criteria for the diagnosis of endocarditis. Certainly, even in the current guidelines, the transthoracic echo remains the number one tool to be used because always and the first tool to be used because it's widely available in the clinical practice. People are quite comfortable using echocardiography. It can rarely identify small structures, but many of these patients will require transthoracic echocardiography, transesophageal echocardiography, particularly even when the transthoracic echo is positive, you want to confirm by TE. If the transthoracic echo is non-diagnostic, and it's very, very important, if you have a prosthetic wall or if you have a intracardiac device, in that case, a T is kind of mandatory. T kinds of gives incremental more information than transthoracic echocardiography, and many of the time you will not see with some suspicion in this view, but if you look at the T pattern, you will see very, very clearly that you can see large oscillating vegetations, particularly in the posterior structures and the structures behind the mitral wall, then the T outshines as compared to transthoracic echocardiography. So from the guidelines, what it appears, one of the major criteria is in the field of guidelines is vegetation, and it remains same unchanged from 2015 to 2023. These are oscillating or non-oscillating material, which can be seen in the intercardiac structures and the cardiac walls, not necessarily on the walls, in other intercardiac structures. And if you do a surgery or an autopsy, you can find the specimens which are consistent with the vegetation. So they remain still as a major criteria for the diagnosis of endocarditis, but the new guidelines say that this can be identified just not by echo, by other modalities, by anatomical modalities, or by functional modalities in that, for that matter. 3D echocardiography role has come up. The 3D echocardiography is very, very important because it allows to look at the volume of the mass of the vegetation. So it actually accurately analyzes the vegetation morphology and size. And not only that, typically a vegetation which is more than 5 millimeter or 10 millimeter has got a very high chance embolism. So it is a better prediction of embolic risk. It is also very, very useful to see the extent of the perivalvular extension of the infections, wall perforations, prosthetic wall dehiscence. So the T has got an incremental role, and the advisable, if you do a transesophageal echocardiography, then it should be always coupled with a 3D pattern of the imaging for him. So what the guidelines say, another major criteria, we saw vegetations, another major criteria remains is a perivalvular abscess. The abscess is nothing, but they are the small cavities which filled with purulent material or necrotic material, and these are cavities which are adjacent to the valvular structures of the vegetations, and they are actually, you can see very, very well on transesophageal echocardiography, more better than by transthoracic echocardiography, more better than 3D echocardiography than by 2D echocardiography. Sometimes these vegetations, they tend to rupture, and this perivalvular abscess, they rupture inside the intracardiac cavities, And in that case, they get transferred to a structure which we call as pseudoaneurysms. So pseudoaneurysm nothing but pulsatized perivalvular spaces, echo-free spaces. Why echo-free? Because the pleural material was there. Now the pleural molecules are discharged into the bloodstream, and you can actually see very, very clearly the color flow images that the blood is going inside the cavities and is coming out. And obviously, the common valvular structures are mitral wall and aortic wall. In both these structures, the transepiphyseal echocardiography will give you a heightened or a better appearance than you can see by transthoracic echocardiography. We have a third major criteria, which is the dehiscence, but in order for the shortest time, I'm not going to the examples of that. So whether you take vegetations or you take abscess, it is actually the TE which is far more superior than transthoracic echocardiography, and the pattern of change occurs in the level of sensitivity. So the specificity for both transthoracic and transesophageal remains the same, but the sensitivity increases from nearly 70% to nearly 90% when you take T is in account. That means what? It means that in order for you to say by certainty there is no endocarditis, you really have to do T. So I really have to emphasize that the guidelines emphasize that if any problem is there, any doubt is there, please proceed directly to transesophageal echocardiography. So once again, to summarize what we discussed and what do the guidelines say, in a patient with suspected endocarditis, the class 1 recommendation is the baseline assessment and initial classification, that is suspicion. Then you do blood cultures and you subject the patient to transthoracic or a transesophageal. This remains as a class 1 indication. Taking further, what is changed in 2023 is the emergence of the modalities which was initially class 2 in 2015 guidelines to class 1 recommendation. So whether we talk about cardiac CT or you talk about FD and FDG PET scans, or you talk about for the nuclear scans or the MRI, they have been all upgraded to class 1 because the guidelines recognize that these modalities have advanced, the imaging system has become more advanced, they have become time sensitive, then the people have developed more experience, and the resolution increased to the extent that sometimes they compete with the echocardiography, and in some areas they are even more superior than echocardiography to define the evidence of infection in the valvular or a perivalvular material. For example, if you take the multi-slice CT, which is very, very commonly available across practically every hospital in UAE has got a multi-slice CT, it is a very excellent tool for the diagnosis of endocarditis and cardiac complications. Particularly when we talk about prosthetic material, where the echocardiography we have artifact reverberation artifacts causing problems, but you can really see abscesses, dehiscence, and pseudoaneurysms, and the guidelines say that it is possibly superior to echocardiography for the information regarding the extent and the consequences of perivalvular infection and the extension. Not only that, if you do the whole body CT scan, you go and deduct distal lesion and the source of bacteremia. So in many, many centers, you will do a whole body CT scan and you find the satellite infections in the liver, in the kidneys, and or even myocardial aneurysm inside the brain. So the multi-slice CT is very, very important. And there are a number of examples which shows very, very clearly. Like for example, in this patient, you can see very clearly there is a perivalvular extension, there is a large pseudoaneurysm, and in some cases you can see, like in this case, aortic wall endocarditis, there is pseudoaneurysm, and you can see actually very clearly many times if there is an abscess cavity in the perivalvular area. Another point which has come up is the use of FDG PET scanning. So FDG PET scanning has taken a tremendous role, particularly in the case of prosthetic wall endocarditis. Now, among all the conditions in cardiology, is a prosthetic endocarditis, which is very, very challenging. If you have a clear aneurysm, or you have a pseudoaneurysm, or you have an abscess, then the diagnosis becomes much more easy. But many patients did not reach that stage. In that case, you have to look for the evidence of infection by using some metabolic imaging, and FDG is a good metabolic imaging because it allows us to look at the abnormal activity at the site of prosthetic implantation. Now, this is true if the prosthetic wall is more than 3 months old. So you have to really have the maturity of the wall more than 3 months old, because before 3 months, you can have sign of metabolic activity without having infections, and you can do certain tests. For example, you can do a fatty meal before the procedure for nearly 24 hours in order to enhance the specificity and the sensitivity of FDG imaging. And for example, you can see in this endocarditis, there are multiple levels. You can see if you have 2 walls, you can really identify which wall is the one which is infected instead of thinking that both the walls can be defective. Once again, one more tool which has come up, and also this is very, very useful in a patient with the prosthetic wall, is the radio-labeled leukocytes by using a SPECT scanning, and the SPECT is a nuclear scan. So you can give them injected WBC which have been labeled, and these WBC, they accumulate at the site of infection in the time-dependent fashion, causing enhancement, and this you can really pick up in imaging. So the European Society feels that all these imaging tools can be used as a class 1 indication for the diagnosis of endocarditis. Now we come to the other areas that what do you integrate for the native and the prosthetic wall? After the initial assessment, once again, like we said, we have a cardiac CT and the PET scanning and the WBC lateral SPECT. So all these tools to be used in conjunction, in tandem, simultaneously to decide the patient is having positive endocarditis or not endocarditis. And once you diagnose endocarditis, then you come the timing of the treatment. Initially, we used to say that all patients with endocarditis requires 4 weeks, 6 weeks of parenteral antibody therapy, and they will stay in the hospital. Until recently, we had some patients, we'll keep them 6 weeks into the hospital. One pregnant lady, she stayed for nearly 6 weeks into the hospital, even after surgery. But now the guidelines say that this patient can be discharged home. And how you can discharge? Typically, on the after surgery or after the infection has settled, typically on the 10th day, do a transepiphyseal echocardiography. If the T is clear and the patient is febrile and the indices have come down, they can go home on the outpatient parenteral antibody therapy, or sometimes you can even think of giving them oral endocarditis treatment. And the last slide, I'm going to show you that how to deal with the patient with the surgery. Like we told you, 50% of patients, they will eventually go for surgery. And the most of the time, the reason for surgery is the local complication, such as abscess, false aneurysm. And typically, one more thing which has been more clarified in the 2023 guidelines is the embolism. So if you have vegetation more than 10 millimeter, then in that case also becomes an indication for surgery, because these vegetations have a high risk for embolism. Or if somebody vegetation is smaller because they are embolized and there is evidence of embolism, then in that case this remains surgery, indication for surgery, and they are defined emergency urgent like acute coronary syndrome. So they become more tighter when to subject the patient for surgery, and I doubt, I did not see in UAE at least anybody going for surgery within 24 hours. So with this, I come to the end of the talk. And one important thing, they said that endocarditis patients should be managed in the center of excellence with the endocarditis team. So a team should include just not the cardiologist, a good cardiosurgical team. So like all of the facilities should go to a higher center, not to be managed in every hospital.
Outstanding. Thank you very much, Dr. Agarwal.